Hello and welcome to Talking Health TV, where we explore the most pressing health issues and innovations shaping our world today. I'm Dr. Milton Brown, and today we have a truly inspiring guest. Dr. Samantha C. Johnson is a medical doctor from Jamaica with a profound commitment to making healthcare accessible and equitable for all. A graduate from the University of West Indies, Dr. Johnson is pursuing her MSc Masters in Public Health and Health Promotion at Brunel University, London, as a 2023-24 Chevening Scholar. Today, we explore her journey, insights, and her work to empower individuals and healthcare professionals. Hi, Samantha, or Dr. Samantha, shall I say?
Hi.
Let's get straight into this. Can you tell us about your medical journey and what inspired you to focus on accessible healthcare?
Sure, of course. First of all, thank you for having me. I'm really excited. But my journey towards this was actually kind of all over the place. When I first started medical school, I really had it with the intention of doing research in psychiatry. Starting medical school, did not like it at all, did not like hospital medicine, but I was lucky enough to discover community healthcare and public health in fourth year, and it completely changed the course of my life. And I always tell this one story, what got me into wanting to improve access. We were telling a story about our experiences in primary healthcare, and we started stories were being shared about persons who had chronic diseases like diabetes, hypertension, but also not having the understanding that these are chronic lifelong diseases, and thus asking certain types of questions within the public health space. And I didn't really like the reaction of the future healthcare workers in the room. And I thought to myself, these things really shouldn't happen. And to me, it felt like it was a failure almost on our part, because I think that healthcare workers are advocates for their patients. And it's a part of our duty, I think, to do health promotion. And this is more than just in the office, but even on a wider scale, on a public health scale as well. But however, in certain countries, especially developing countries, it can be very hard to give the type of healthcare that you want, just because of the resources and the constrictions that we have within our own healthcare systems. So that's why I wanted to do accessibility and focused on all major components. So that's the healthcare system, patients, as well as our healthcare workers.
That's amazing. What year was this then when you decided I'm going to...
So this was in 2018, so 1 year before I graduated from university. And I decided it was also another way for me to be committed to writing. I like to write a lot, and it was a way for me to escape too. So in 2018, the idea popped in my head. I liked blogging. I made the website, and I thought, what should I call this? And all of a sudden, it popped up, the layman's doctor, because I wanted to almost be an advocate for the layman and speak a lot in layman terms about when I talk about medicine.
So if you can touch a bit more on the layman's doctors and healthcare system, and you've also the founder of a Margin 2 Center. Can you touch on that, please?
So I'll start with the layman's doctor. It's a platform. So I have written articles, I have a blog post, I also have a podcast as well. But as a part of the layman's doctor, I've been able to be on panels, have conversations, and even do some types of consulting. For example, when PrEP was being introduced, I was asked to consult on that. So it's been a really amazing experience that started from this one blog, and it really focuses on bridging a gap. I'm really interested in gap filling and being bridges and talking about the healthcare system in a way that, I hate to say the word again, but accessible. And I don't really focus as much on explaining what is diabetes or what is hypertension. That information is out there. I found what people had issues with in my context was coming to the emergency room department for things that could be seen in a primary care setting, but also not really knowing the differences between these two health systems, or sometimes not knowing how to advocate for themselves even. So one of my earlier articles was about questions to ask your healthcare provider when you're there. I've even written something about what to wear to clinic. but sometimes for persons it's the first time they're ever there and these things are not common knowledge, then margin to center is a more focused version of that. I've always been interested in advocacy. I've always been a part of advocacy as well. And I created Margin to Center with three other lovely women in healthcare. And they were amazing enough to believe in me and my vision and take on this project. And we were lucky enough to be funded by Frida, which is a feminist organization that tends to fund grassroots organizations. And we're focused on improving access to healthcare for marginalized groups of women.
It sounds to me you're challenging a lot of historical and structural health practices. How are you received from them?
So it's something I've always done. And I think what's really funny to me now is that a lot of persons are now reaching out to me and being like, when we think about inclusivity and diversity within the medical space in Jamaica, a lot of times you pop up in my mind. And one thing I did, I remember when I was in medical school, I was the first person to actually have a whole session for medical students that talked about how to speak to persons who had HIV or persons a part of the LGBT community outside of how they're spoken about in a vignette, which is very stereotypical, but to actually talk to them like human beings, like regular, degular persons. And that was pretty controversial. I did have to fight for it. But that led to me being a part of the group.
The group,
Yeah, where they were trying to make the education more exclusive or inclusive rather. And I remember even when I graduated, one of my lecturers, I reached out to them and said, hey, we need to start teaching empathy in school. Like international schools, they have modules on this. This is something that can be taught. It doesn't have to be a natural talent. And I remember going all the way up to sending the email to the dean. And unfortunately, it didn't really go anywhere. And for me, a lot of times I said, you know what? I will do it. And something I really want is that if I start, I want other persons to kind of follow. And I want persons to be involved and also portray those items in their own spaces, because I think we can all be advocates within our own communities and we can touch persons no matter how small the group is or not.
And again, I want to ask another question because I'm trying to keep an international Jamaican focus as well as how it relates to us here in the UK. What about those access to, we call them GPs here. I know it's accessibility. And then you have people with different sexual orientations. How is that received? And could you please also touch on the blind or deaf people as well?
Okay, this is in a context of Jamaica or?
No, I think whatever Jamaica's doing as in terms of accessibility and inclusivity, it's got to be good for everywhere.
Well, I would say that we've gotten better at it. When I was studying, especially when it came to persons from the LGBT community, Jamaica does have quite a reputation with that, but we have improved very much over the years to the point now where healthcare workers are being trained even by the persons. It's being facilitated rather by the government to have persons have training in these areas. Unfortunately or fortunately, it tends to start out with clinics that are maybe more focused on sexually transmitted infections, but then that it has started to spill over into chronic illnesses and more primary care levels. So it's a kind of a way to sneak in. We just recently passed, and I said just recently, it's maybe about a year, so we just recently passed a Disability Act. So now on paper, we are supposed to be accessible for persons with disability. And we need to remember that this includes physical access in terms of the infrastructure, but also when they relate to persons. So I think we're getting there. There's so much more we can do. And what I will say is here in the UK, it's my first time experiencing the healthcare here. And I mean, a lot of the things that we'll see in the news, wait time for GPs, even I've experienced it, and I have a health center on campus. But one thing I like is that they have volunteers here that will speak a different language and it will help with the communication. It may not be perfect because ultimately you want someone who's trained in interpretation, but even that is a nice way to bridge the gap. And you asked me to touch on persons from the deaf community, for example. One story I had is I saw a deaf patient and I only know a little bit of sign language. So I knew the bare minimum, but luckily I also knew one of our interpreters, and they were very happy to help me with the interpretation. Ultimately, I didn't need it, and luckily the case wasn't so severe that I really felt like I did a disservice. So at the end of the day, I did feel unsatisfied with the level of care I was able to deliver. But within that setting, I did probably the best I could. I tried to make sure that I wrote down as much information I can for persons around to be able to know what happened, and also use material that if they didn't follow up, that they could, it would be okay, more or less. But those are the things I had to think about. And maybe something I really shouldn't say, but sometimes when that patient came in, or patients like that come in, a lot of times I do get pushed to do that because it's kind of my branding at this point. And
Everybody seeing you as a bit of a savior.
from university to now, I was always kind of seen as, they used to call me the J Flag girl, and J Flag is one of our NGOs back home that works a lot with the LGBT community. So I think it's good, and I'm really hoping I can inspire other persons to really take charge and do the same or more.
Yeah. So the training that you might give some of the volunteers and students now, are you actually learning sign languages in the training?
So Margin to Center is still a baby. And right now we did 2 projects. So one is out now, and that's the Jamaica Sign Language, or Introduction to Jamaican Sign Language for healthcare workers. And I like to call it like a appetite whetter, because what I really want to push through this is to get healthcare workers interested in learning about the deaf community and learning sign language, and maybe even going on to learning interpretation as well. And it's also a way for me that I want to connect the deaf community and get to know who works in the space. So even when we developed it, it was developed by persons from the community. We engaged the community. We did our needs assessment by talking to both hearing and non-hearing persons who worked in the NGO sector for them, schooling sector, and persons actually from the community. And something I did, I actually worked at a cafe, and we have something in Jamaica called Deaf Can Coffee, where it's a lot of the workers are deaf. So I worked at a cafe that exclusively employed persons from that organization. And yes, I did try and use it so I could learn, I could practice my sign language, because if you don't use it, you lose it. And it was a really nice experience. And I think it really cemented my interest and passion in that these things shouldn't limit your ability to get high quality healthcare.
How much do you know of the West looking at Africa and the Caribbean and Latin America to inform their practices of people who've got similar demographics?
So I think they should, and I think a really good example of this is actually sickle cell.
Okay, definitely,
right?
definitely.
Sickle cell is a great example because you will find that in countries that have majority Black persons, which is what sickle cell is most, we're the ones who generally will have sickle cell. Jamaica, we have our sickle cell unit. We've done quite a bit of research in sickle cell. And I think here, there's a lot of advances in technology that is very useful. But then because I don't think the experience or the knowledge with sickle cell is here. And one of the things is maybe here they may be diagnosed a bit later. But, when I hear a story of someone who was diagnosed with sickle cell maybe at 12, and in my head I was like, wow, we do screening and certain things. When you come and you say those symptoms to us or these experiences, one of the things we automatically kind of have in our head is like, okay, we need to see if this person may have something with their hemoglobin, maybe they have sickle cell or something like that. And I think that's how we can learn. The West, especially as their countries become more and more diverse, it's very important to start looking at these countries as equal partners, persons you can learn from, because you can learn anything. I can learn something from a 3-year-old. These children are amazing. I can learn something from someone who is 75. So we need to, I think, look at it that way and open our minds. But then on the other hand, I think developing countries, we need to write things down more. And especially when it comes to research. So when I went to Ghana, something I saw was they had a medical practice book made for Ghana. And I always thought that's something that would be amazing in Jamaica. We have all this data, and we should be able to utilize that data to be able to adapt in a uniform way across the country certain treatments.
Before I go on to the next question, though, because I'm really finding the conversation fascinating. Because what about alternative medicine, like
Oh, I
go
love
down a bush
alternative
and
medicine.
pick up a leaf and rub on your head and bear rum and all of them kind of things?
So I love alternative medicine.
Yeah, yeah.
And, you know, one of the most controversial things I'll say as a doctor is that I don't believe in medication.
Okay.
And there's always an asterisk to that. There's a caveat to it. I think that medication is a good supplement and you use it when you need it, right? But especially like for lifestyle diseases and chronic diseases, you know, we have to look at different things as well. And then for alternative medicine specifically, I mean, for years and years and years, people have been using this. You have things like garlic that helps, that has antiseptic properties and lowering blood pressure properties. When I was in Ghana, we visited an alternative clinic where they treat so many things with alternative medicine. And I think what we may be lacking is more research into these things and being able to see, well, they've been using these things historically. Let's see if we can put some science behind it so we can actually utilize it. And maybe what ends up happening is we have someone with high blood pressure coming in, and when you say, oh, you know, have a low salt diet or eat properly, it's more specific advice. You can start saying maybe eat more garlic to help with blood pressure, or you have some ginger. I was sick the other day. My friend from country said, make a tea with lime, garlic, and ginger. Drink it 2 times a day, and best believe, not only did it taste good, it actually really helped. I'm a huge advocate for alternative medicine.
Wow, that's really interesting. What are the key components necessary for promoting diversity, equality, and inclusion? And I would also add equitable opportunities for health in the healthcare sector.
So I think in countries that have multiple ethnicities, even more so, there has to be a look and focus on social determinants of health, because what the data sometimes doesn't show you in a very obvious way is that when you look at, for example, a Black person having worse outcomes, sometimes that's all you see, but you're not seeing, okay, Black persons may be more likely to be impoverished. So, you know, it's harder for them to access because of monetary issues, even if there's free healthcare, because you still have to travel there. You still have to maybe buy things, the wait times, things like that. We're looking at cultural differences as well. And for cultural, it's also how we interact with patients and understanding their culture. Because you can imagine going to a doctor or a healthcare practitioner or a psychologist, especially, you're talking, but they don't really understand your culture. Sometimes the advice can maybe go over their head because it may not be relevant. But I think it's really important that we look further into the statistics and kind of look at the why. And I think when we go to the root of the issue, we can maybe improve it. And health is something that encompasses everything. It touches on almost, if not everything. So if you want to solve health issues, it also means solving even things like transportation, solving employability, education. And it's one of those things that touches on everything. And I think that's why I really love healthcare and public health especially.
Digital access.
Yeah.
And certain communities are digitally impoverished. Certain communities are digitally marginalized. How do you get around that in Jamaica, and what advice would you give to UK?
Oh, so, I mean, I have a lot of thoughts about technology in health, and I am an advocate for it, but I think we do have to be careful with it. I think sometimes we put the cart before the horse. There are places that don't have this access. There are places that only have persons who only have a cell phone or have a smartphone. So I think we have to think very carefully about access, because what may actually end up happening is the reverse. Imagine if, like, for example, to go to my health center, they tell me to go on the website or use an app to book. And I'm just like, I'm right here. Why can't you just book an appointment for me? But things like that, if you don't have internet access, or you don't have a capable smartphone, or you don't even have the knowledge or the literacy level to actually utilize this technology, we need to start thinking about digital skills and empowering our community to be able to utilize all of these new devices and products that we have coming out.
Okay, finally, what advice would you give a young medical professional, aspiring health leaders who wish to make a difference in their communities?
So I think this is a really great question because it always helps me to reflect. And this week has been one of those weeks where I had to remind myself to pause and sometimes look back at the things that I've done. And something I would say is chart your own path, and it can be very hard to do, especially if you're from the Caribbean, where a lot of times medicine just seems like hospital medicine. But being a doctor, being a nurse, being in healthcare makes you have a lot of transferable skills. I never would have thought that I would have been interested in venture and be interested in investing and advising, strategic advising. But turns out I really like it. I think I can be really good at it with more practice. So chart your own path. I would say journal and take the noise of everybody else out of your head and give yourself time to talk to yourself and listen to the things that you really and truly want and follow your energy. Your body really tells you when something is for you and when it's not.
I want to say a big, big thank you. Such an enlightening conversation. Thank you for joining us. Dr. Johnson's dedication to accessible healthcare, particularly for marginalised communities, is truly inspiring, and we wish you all the very best. To our audience, we hope you've gained invaluable insights into the importance of health promotion, diversity, ethical healthcare, and practice. Join us next time on Talking Health TV, where we bring you more inspiring stories, experts, insights from the world of healthcare. Until then, stay healthy and stay informed. Goodbye.